Appreciate
Good morning. It's my pleasure to welcome you to the Subcommittee on Labor, Health, and Human Services and Education to discuss the fiscal year 2016 National Institutes of Health budget request. We're looking forward to hearing the testimony of Dr. Collins and some of his distinguished colleagues. I'd like to publicly thank Dr. Collins and the staff at NIH for hosting me and 5 other subcommittee members for a briefing and tour of the NIH campus a few weeks ago. I think it's safe to say we all left the NIH with a deeper appreciation of the exciting work your staff do every day to find ways to save lives. The scope of biomedical research supported through and at the NIH is wide, and we're confident that thanks to the talented staff and scientists that work there, we'll one day find cures for diseases like cancer and Alzheimer's. Ensuring a sufficient basic biomedical research base and supporting the next generation of researchers is critical to pave the way for these long-term advancements. Your budget assumes many areas of enhanced spending on genomic activity, including a focus on Ebola, universal flu vaccine, antibiotic resistance, and Alzheimer's research, to list only a few. Of course, we all support biomedical research. Unfortunately, right now, sequester is the law of the land, and given the reality of funding allocations, we might not be able to do everything that the administration is proposing absent a larger bipartisan budget agreement, one, quite frankly, that I hope we achieve. I look forward to having a discussion with you this morning on your top priorities for this year, given our funding constraints. I would also be remiss if I did not point out how important it is to ensure that we continue to focus on the next generation of investigators. We know how long it takes for a new drug or treatment to make it from lab to the patient. So without a pipeline of young researchers committed to following the scientific process of investigation and experimentation, we won't be able to find the cures we seek. Today, we welcome Dr. Francis Collins, the NIH Director, to the subcommittee. Dr. Collins is accompanied by 5 of his distinguished institute directors who can assist in answering specific member questions. They are Dr. Anthony Fauci, the Director of National Institute of Allergy and Infectious Diseases, Dr. Thomas Insel, the Director of the National Institute of Mental Health, Dr. John Lorsch, the Director of the National Institute of General Medical Sciences, Dr. Nora Volkow, the Director of the National Institute on Drug Abuse, and Dr. Gary Gibbons, the Director of the National Heart, Lung, and Blood Institute. As a reminder to the subcommittee and our witnesses, we will abide by the 5-minute rule. And before we begin, I'd like to yield the floor to my chairman, the gentleman from Kentucky. After that, we'll move to our ranking members, the gentlelady from Connecticut, and then to the gentlelady from New York, our ranking member on the subcommittee, or excuse me, on the full committee. So with that, Mr. Chairman, you're recognized.
Mr. Chairman, thank you very much. Congratulations on being the new chairman of this great subcommittee and the responsibilities that you've gladly taken on. Welcome to all of you. Thank you for being here. Dr. Collins, your leadership role in the groundbreaking International Human Genome Project is just one example of your many talents. I'm told that another one of your talents is playing guitar, apparently. Apparently very well. So, you know, you've got something to fall back on in case this don't work out. Unquestionably, you all are at the helm of research at NIH during a time that demands our country's interest and investment in medical research. The recent Ebola epidemic in West Africa highlights the importance of NIH's mission to gain and apply knowledge to enhance health, lengthen life, and reduce illness and disability. Medical research is one of the most important parts of preventing future epidemics and developing cures for diseases that are not preventable. The NIH Fiscal 16 budget request highlights priorities such as Ebola, Alzheimer's disease, and antimicrobial resistance. In addition to the public health benefits that accompany NIH work, the economic impact of medical research should not be underestimated. NIH research dollars not only impact research and facilities and researchers, but they also help get new drugs and devices to the marketplace. And I'm pleased that you've seen fit to invite Dr. Nora Volkow to join us this morning as the director of the National Institute of Drug Abuse. Dr. Volkow has been a true pioneer in the science of drug abuse and addiction. She was one of the first people in history to use brain imaging to investigate the effects and addictive properties of abusable drugs, and her research has undoubtedly made the world that we live in a much better place. She's been with us since day one as we've battled drug abuse in my area in southern and eastern Kentucky, hard hit especially early on by OxyContin and others. And I'm looking forward to seeing both of you, in fact, at the Atlanta Summit on prescription drug abuse this summer. And I thank you for coming last year and helping us battle this prescription drug abuse scourge that's killing more Americans than car wrecks. And we appreciate your dedication to that especially. We look forward to hearing also from you today about the two critical drug-related issues. First, I'm pleased that NIDA, under Dr. Volkow, is pursuing an adolescent brain cognitive development study, ABCD, to collect rigorous longitudinal data on the effects of marijuana, alcohol, nicotine, and other drugs on a young person's brain. It's unfathomable to me that states continue to pursue policies to decriminalize or legalize marijuana in contravention of federal law, I might add, even here in the nation's capital. It's ironic that in Washington, D.C., the nation's capital, you can't smoke cigarettes, but you can smoke pot. Explain that to me. Help me out. We don't have scientific data to tell us about the long-term impacts of marijuana use on the brain, but hopefully this will open a lot of minds. This study will help close that gap, hopefully bring some much-needed sense to the conversation about marijuana use in this country. Secondly, Dr. Volkow, I'm interested to hear about recent efforts regarding the abuse of prescription medications. As you well know, that's been characterized by your colleagues at CDC as a national epidemic. I understand that you're partnering with 9 major pharmaceutical companies to evaluate the risks associated with the long-term use of opioids for the management of chronic pain. If there are non-opioid alternatives to the treatment of pain, we need to know about them, and doctors need to be educated about them. I'm also hoping that you can provide us with an update on the science of abuse-deterrent medications. It's remarkable that OxyContin, the drug that caused so much difficulty, and it still is, but mostly back in the 5-6 years ago, the pill, the drug was changed to make it drug abuse deterrent. You can't crush it, you can't snort it, you can't inject it. It still retains, though, the good qualities of relieving pain over an extended period. That's what can be done. to stem the use of opioids, and I commend you for it. In addition to our long-standing struggles with drug addiction and abuse, the research provided by NIH is critical to understanding, preventing, and developing cures for ailments like diabetes, cancer, and heart disease that continue to plague my region especially. We're very proud of the partnerships we've established with NIH in Kentucky. For example, the Markey Cancer Center, a National Cancer Institute designated cancer center at the University of Kentucky, and the UK Center for Clinical and Translational Science, which previously received your prestigious Clinical and Translational Science Award for its work to confront chronic health issues in Kentucky and rural populations, especially in the Appalachian region. Currently, 22 of the world's 50 top-ranked universities for life sciences are in the U.S., and we must continue to foster the next generation of scientists. We look forward to continuing these important collaborative efforts as we work together to bring an end to these devastating diseases. We thank you for being here, and with your colleagues, Dr. Collins, we expect to hear some good stuff. How you?
Thank you, Mr. Chairman. Next, we'll go to Ranking Member, distinguished gentlelady from Connecticut, and frankly, a tireless champion of this particular agency for many, many years.
Thank you very much, Mr. Chairman. And good morning to everyone. It is a little earlier than we usually start these hearings, but it's such an important topic that it was important to all of us to have the opportunity for the full 2 hours with a distinguished panel. I'm so thrilled to welcome you, Dr. Collins, the Director of the NIH, Dr. Fauci, Dr. Volkow, Dr. Insel, Lorsch, Gibbons, to discuss the 2016 budget request for NIH. First and foremost, let me just say thank you for your work. Every scientific discovery, every medical breakthrough, the research you support advances human knowledge, and it improves the quality of our lives, and most of all, it saves lives. And as an almost 30-year survivor of ovarian cancer, I am alive today because of the grace of God and biomedical research. When I was elected to the Congress, I made supporting that research one of my top priorities. As well as improving health, research also drives our economy. As the chairman said, every dollar invested in NIH repays more than double that in local economic growth. NIH is the cornerstone of our life sciences industry, which employs more than 7 million Americans, adds almost $70 billion to our GDP. So there is no reason not to fund NIH as fully as possible. In January of this year, along with the chairman, I had the pleasure of touring the NIH, and along with other members of the subcommittee, it was, as always, a fascinating visit. While there, we met with a senior investigator, Dr. Nancy Sullivan, who is largely responsible for one of the Ebola vaccine candidates that's currently being tested in a clinical trial. That clinical trial is only possible because, thanks to NIH support, Dr. Sullivan and her colleagues have been able to pursue a vaccine over many, many years, since 1997, in fact. Research can take a long time to bear fruit, and if we do not invest now, we will not be able to benefit from scientific discoveries 5, 10, even 20 years from now. So it is troubling to me, deeply troubling to me, to note that since fiscal year 2010, after adjusting for inflation, NIH has seen its budget erode by about $3.6 billion. That's an 11% cut. Sequestration is terrible policy for any budget. It is especially cruel where there are literally lives at stake. In 2013 alone, sequestration took more than $1.5 billion from the NIH. Even after modest increases over the past 2 years, we still have not returned NIH's budget to its pre-sequestration level. A decade ago, NIH was able to fund almost 1 out of every 3 applications for research grants. Amid sequestration, that success rate has fallen to 1 in 6. In 2015, NIH will fund almost 1,000 fewer research projects than it did in 2010. We will never know how many scientific discoveries and medical breakthroughs the world may have missed out on because of these budget restraints. That is the disturbing context in which we consider the NIH budget request for fiscal year 2016. Overall, this request starts to set us back on the right track. There are some exciting initiatives in this budget. The Precision Medicine Initiative will help doctors provide treatments finely tailored to the individual characteristic of each patient. The Combating Antibiotic-Resistant Bacteria Initiative, CARB, focuses on defending against deadly superbugs. The BRAIN Initiative holds the potential to revolutionize neuroscience and to make advances to treat Alzheimer's, autism, and many other brain disorders. The budget includes funding for research to develop a universal flu vaccine and potentially a cure for HIV/AIDS. It also supports basic science research that has long-term benefits across multiple fields. As I've said, I believe this is the right track. But given the severe neglect of NIH over the past few years, I am disappointed that we are not restoring funding more quickly. This request restores less than one-third of the cuts since fiscal year 2010. I introduced a bill in the last Congress and again in this Congress that would enable our committee to increase NIH funding by 10% this year and 50% over 5 years by providing a cap adjustment. That would ensure proper funding for research without robbing other vital programs to do so. We have invested strongly in NIH before. In the 1990s, I was among a bipartisan group of members of both chambers on this committee who fought to double NIH's budget over 5 years. To this day, it stands among my most proud achievements. Instead of starving the NIH of funds, we should be seeking to repeat that achievement and double its budget again. But this investment cannot happen unless and until we undo that failed policy of sequestration and summon the courage to ask those who can, the wealthiest, who have done so well in recent years, to contribute more to support our national priorities. Biomedical research gives us the gift of life. It has done so for me and for countless others. That is what the NIH represents. We can and we must find the resources to support it. And I thank you. I thank you, Mr. Chairman.
Thank you. Next go to my good friend, distinguished gentlelady from New York, for her opening statement.
Well, thank you, Mr. Chairman. It is a pleasure for me to be here today. And I'd really like to thank Chairman Cole and Ranking Member DeLauro for holding this hearing today. It is such an honor for me to have such a distinguished group of public servants, Drs. Collins, Fauci, Insel, Lorsch, Volkow, and Gibbons. I really appreciate your being with us today, and I thank you for the life-saving work that you do every day. Throughout my time in Congress, federal funding for the National Institutes of Health has been among my very top priorities. The NIH is the world's premier research institute. Its researchers have mapped the human genome, and I do remember, Dr. Collins, that empty shape that you have filled up. It's really amazing. You have created vaccines that are being tested to prevent the spread of Ebola, developed advances in cardiovascular disease that have reduced death rates by more than 60% over the last half-century, and invested in HIV therapies that turn what used to be death sentences into longer, more productive lives. As a result, it is no surprise, but it continues to amaze me that NIH-supported scientists have been awarded no less than 145 Nobel Prizes. Not only does NIH's work improve the quality of life for millions of Americans, it is also a springboard for economic growth, generating 2.21 in economic activity for every dollar invested. And I remind my friends and neighbors all the time that not only are you moving ahead and saving lives, but you're creating jobs. Your 2016 budget request proposes an increase of $1 billion, resulting in 1,200 additional competitive research grants. It would make welcomed investments in advanced cancer treatments with a new precision medicine initiative, increased funding, as my colleague Ms. DeLauro said, for the Brain Initiative to research the workings of the brain, develop treatments to combat Alzheimer's disease, autism, and other neurological and psychiatric conditions. These are the very definitions of worthy federal investments. The President has also called for the end of the mindless austerity of sequestration. In fact, I've even heard some of my colleagues on the other side of the aisle refer to the mindless austerity of sequestration, urging Congress to replace it with more targeted spending cuts, program integrity measures, closure of some outdated tax loopholes. I could not agree with him more. The effects of sequestration are immense and are still being felt. In 2013 alone, sequestration reduced the NIH investments by more than $1.5 billion, and FY 2015 funding is still below the pre-sequester level. Many critically important research initiatives were abruptly halted. It really was a worst-case scenario for many agencies, and we have to make sure it does not happen again. The United States must keep pace with the rest of the world. While NIH funding is $3.6 billion, or 11% below the FY 2010 level when adjusted for inflation, others are making substantial increases. Between 2007 and 2012, China increased their biomedical research spending by $9 billion. Increased. While others are advancing, our investments in biomedical research are just not keeping up. As we begin the annual process of crafting a budget resolution, I know there will be many viewpoints. Many of my colleagues may undoubtedly press for additional cuts and to leave the outdated sequester level caps in place, but I think we all know how dangerous that is. Discretionary funding, which includes biomedical research, education, job training, transportation infrastructure, and clean energy development, is falling to its lowest level as a percentage of GDP since the Eisenhower administration. We must act to ensure reasonable allocations for the important programs and investments funded through the appropriations process, especially the National Institutes of Health and those under the jurisdiction of this subcommittee. I look forward to your testimony. Thank you again for being here before us, and I look forward to the NIH's plans for the coming year. Thank you.
Thank the gentlelady, and Dr. Collins, whatever your full statement will be entered into the record, and you're recognized for whatever opening comments you care to make.
Well, thank you, and good morning, Chairman Cole, Ranking Member DeLauro, distinguished members of this subcommittee. It is an honor to appear before you today, as this panel has a long history of supporting NIH's mission to seek fundamental knowledge and apply it in ways that enhance human health, lengthen life, and reduce illness and disability. Breakthroughs generated by NIH-supported research are behind many of the gains you see here that our country has enjoyed in health and longevity. For example, over the last 60 years, deaths from cardiovascular disease have fallen by more than 70%. Meanwhile, cancer death rates have been dropping about 1% each year for the last 20 years. And likewise, HIV/AIDS treatments have greatly extended lives, and prevention strategies are enabling us to envision the first AIDS-free generation. The future of biomedical research has never been brighter. Allow me to tell you about just a few of the many exciting opportunities that NIH is pursuing today. Let's start with vaccines. Thanks to NIH research, 2 different vaccines against the deadly Ebola virus are being tested right now in Liberia. Vaccine research is also making exciting progress against a virus that nearly all of us have tangled with, influenza. Currently, a new flu vaccine has to be produced every year based on our best guess of how the virus will evolve, But that approach isn't ideal, as we have learned this past season. So NIH-funded researchers are working to design a universal vaccine that will protect against virtually all flu strains. Such a vaccine could eliminate the need for annual flu shots and reduce the risk of a global pandemic. So I'm excited to tell you that universal flu vaccine candidates have now moved into early-stage human clinical trials. NIH also remains strongly committed to supporting basic science, fundamental research that serves as the foundation for discoveries that have long made America the world leader in biomedicine. One exciting example is the BRAIN Initiative. This bold, multi-agency effort is enabling development of innovative technologies, you see one here, to produce a clearer, more dynamic picture of how individual brain cells and neural circuits interact in time and in space. This initiative will give us the tools for major advances in brain diseases, from Alzheimer's and autism to schizophrenia and traumatic brain injury. Scientific advances are also accelerating progress toward a new era of precision medicine. Historically, doctors have been forced to base their recommendations for treatment on the expected response of the average patient. But recent advances, including the plummeting costs of DNA sequencing, now make possible a more precise approach to disease management and prevention that takes into account individual differences in genes, environment, and lifestyle. With this in mind, we are thrilled at NIH to take a lead role in the multi-agency precision medicine initiative. In the near term, this initiative will focus on cancer. To accelerate efforts, this project will support research aimed at understanding why cancers develop drug resistance, using non-invasive methods to track therapeutic responses, and exploring new treatments targeted to the genetic profiles of a wide range of adult and pediatric cancers. As a longer-term goal of this initiative, NIH will launch a national research cohort of 1 million or more volunteers who will play an active role in how their genetic and environmental information is used to prevent and manage a broad array of diseases. A project of this magnitude will lay the groundwork for new prevention strategies and novel therapeutics. There's no better time than now to embark on this enterprise to revolutionize medicine and move this precise personal approach into everyday clinical practice. In closing, let me share a story that highlights the early promise of precision medicine. When Maki Inada was diagnosed with stage 3B adenocarcinoma of the lung in 2008, it was completely unexpected. She was just 36 years old, never smoked a day in her life. Her tumor was very large, as you see here, 7 centimeters, with a very low likelihood of survival beyond a year or two. As Maki began the recommended standard chemotherapy, her doctor suspected she might have a particular mutation in a gene called epidermal growth factor receptor, EGFR. Genetic testing confirmed their hunch, and Maki was prescribed Tarceva, a drug that precisely blocks EGFR's signal. After 3 months of treatment, Maki's large tumor shrunk dramatically. This was followed by surgery to remove cancerous tissue, plus retreatment with Tarceva. Today, 7 years after her diagnosis, her doctors can detect no signs of cancer. What's more, during the extra time provided by this approach, Maki competed a triathlon, landed her dream job as a biology professor at Ithaca College, and welcomed a healthy baby girl. Clearly, we need many more stories like Maki's. That is our dream, and I'm sure it is yours too. With your support, we can realize our vision of accelerating discovery across the vast landscape of biomedical research, from basic scientific inquiry to more precise, personalized approaches to treatments and cures. So thank you, Mr. Chairman. My colleagues and I now welcome your questions.
Thank you very much, Dr. Collins. And just for the members of the committee, we're going to go first to our chairman, our ranking member, and then we'll go through our normal order in terms of questions. So, Mr. Chairman, you're recognized for whatever questions you care to pose.
Thank you, Mr. Chairman. Dr. Collins, Dr. Volkow, thank you both for your special interest in prescription drug abuse.
Yeah, but he just talked about it.
As you know, every day, about 105 Americans die from overdose, mostly prescription medicine. Sadly, As we've taken strides to address that challenge, we've also seen a rise in heroin use and its consequences as people who are addicted to painkillers graduate to those drugs who are cheaper. I've long advocated for a multi-pronged approach to addressing this unique challenge, and of course research is one of the main prongs of that approach. I'm particularly interested in the development of new technologies that will make these drugs more difficult to abuse, and we've seen some real progress in that field. Effective abuse-deterrent technologies that will ensure that patients truly in need of these therapies can receive treatment, while also ensuring that these very powerful addictive medications can't be tampered with or abused. Let me ask you, what investments has NIH or NIDA made to advance the science of abuse-deterrent technologies, and can you comment on the fruits of those labors, Dr. Collins?
Well, Mr. Chairman, thank you for the question and for your leadership in this area, which is really quite remarkable, the way which you have shone a bright light on the importance of our addressing this, brought experts together as you've done each year and will do again in April. I'm going to ask Dr. Volkow, who is an internationally recognized expert in this area, to address your question. Nora?
Dr. Collins, thanks very much. Mr. Chairman, thanks very much for asking the question and for your interest in the matter. And as you describe it, we do use a multi-pronged approach also in science to address the issue of the prescription opioid abuse problem. One of them is effectively to develop medications that, if they are opioid-based, they have the deterrent formulation so that they cannot be diverted and abused in ways that they can produce addiction and harm. And many strategies have been developed, and some of them relate to a combination of drugs. Others relate to inserting the drug into a polymer so it cannot be diverted. In this effort, we partner with pharmaceuticals, so it's a public-private partnership to enhance the likelihood that the products will get into the market. And again, here innovation has led to very different ways of solving the problem. That's one. The other one is the development of medications and strategies to prevent deaths from overdoses, because they are antidotes. In fact, naloxone is very, very effective in preventing overdoses. And we have, again, partnered with the pharmaceuticals in order to be able to provide with naloxone in ways that are user-friendly and anyone can administer them. And thirdly, as importantly, we cannot underestimate is the relevance of developing medications to treat those individuals that become addicted to opioid medications, because the proper treatment can prevent the overdoses. In parallel, we are also working on implementation research to ensure that people will, and practitioners will provide better screening and treatment of patients with pain, minimizing risks, and as well as substance use disorders.
NIDA is working to develop an abuse-deterrent formulation of OxyContin, using what I understand is called prodrug technology. What is that?
The prodrug technology is you administer a medication that is not active until it suffers a second conversion. In this case, the medication that we're working with Signature Pharmaceuticals, is a prodrug that will not become active until it gets into the gastrointestinal system, and the enzyme trypsin then activates it. The advantage, therefore, is someone, if they want to inject the drug, which is the way that these drugs are abused, there will not be any pharmacological effects because it will be an inactive drug. It requires the enzyme in the gastrointestinal tract to activate it.
What do you think about it?
I think very promising. There's already evidence in the past for prodrug stimulant medications that have shown they are much less likely to be diverted and to produce problem of addiction.
Might mention that Dr. Volkow has taken a personal interest in that particular approach and has worked closely with the company to try to be sure that NIH, in a public-private partnership, can play our role in encouraging that effort to go forward. Ultimately, we hope to FDA approval.
Well, I mean, if this should be successful, is this this is a major breakthrough, is it not?
It would be a very important breakthrough, and we hope that we will be hearing soon. I mean, we're expecting, hopefully, some results in the very near future.
About when?
Well, I'm on a confidentiality agreement, so I cannot give details, but let's say that we hope that we will be hearing soon.
Well, it's an exciting thing. OxyContin, like many other of the opioids, are wonderful drugs for terminally ill cancer patients and the like, 12-hour release. But if it can be crushed and injected all of a sudden, you get a 12-hour release in a split second, and thus the addictive power of this drug. So if you can find a way that we can use its great qualities while preventing it from being abused, that would be an extremely well-liked, life-saving development. 105 people a day dying from drug overdose. How can we incentivize the private companies to invest in the development of these technologies? How can we make it so there's something in it for them?
Well, to start with, and again, it's an example about how science and policy need to work together. As these products are developed, there is research invested and dollars invested into it. So we want to ensure that once these products are developed, physicians will be able to prescribe it, and the companies will pay for those prescriptions. So I think that ensuring that the innovation that results in safer medications that, however, may be slightly more expensive, is supported by the resources that will make it possible for patients to get access to these medications.
Well, I thank you for your work and your dedication. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. The gentlelady from New York is recognized for whatever question she cares to pose.
Thank you. Dr. Collins, the example you gave us of this woman with a growth on the lung is really extraordinary. And what I thought of immediately is every person who goes to their doctor with what I've heard in 2 cases, inoperable tumors in their lung, do they all get that test?
That's a great question, and in fact, one of the things we hope to achieve with the first stages of this precision medicine initiative is to make that kind of experience much more available. Increasingly, individuals who develop cancer are having some kind of analysis done of the tumor to see what's driving it, because we are developing a long list of reasons why good cells go bad and start growing when they shouldn't, and the ability to be able, in the individual, to determine what's going on in that person, and then connect that up with the appropriate choice of drugs. This targeted therapy approach is extremely exciting. In fact, the National Cancer Institute has, for lung cancer, started such a protocol called Lung Map, which aims to do that, in that case for squamous cell lung cancer, and another one for pediatric cancers and for adult cancers called MATCH. But so far, the development of these approaches and the implementation across all of healthcare is not there yet, in part because we don't know quite enough to know what is the best strategy. The Precision Medicine Initiative, by expanding that effort in a very significant way, should make this kind of opportunity available to many more people with cancer. It should also teach us things about why it doesn't work when you think it should. I gave you a beautiful example of a remarkable cure, but we don't always see that, and we don't know why when it doesn't work something is responsible, or why when it seems to have produced a remission and then the disease comes roaring back a year later. What's that about? If we could understand the causes of relapse, that would help us. And another thing which Precision Medicine Initiative will focus on is the opportunity to find out, could we combine more than one targeted therapy, or perhaps combine a drug therapy with immunotherapy, which is extremely exciting right now. and have a higher likelihood, not just of remission, but of cure. All of those are ripe for investigation. This initiative aims to really turn up the heat in getting those kinds of answers.
But it's still not widespread, is what you're saying. I just recently have two friends who had inoperable lung cancer. And I just wondered if those tests were available to them, but you're saying it's not that widespread.
Increasingly they are, but I would certainly say to anybody who develops cancer at this point who's interested, go to clinicaltrials.gov, find out what trials are currently being conducted all over the country, many of them supported by NIH. Find out whether you qualify for one of these studies that would include this kind of DNA analysis of the tumor and an opportunity to match that up with the available therapies.
I am particularly interested in how precision medicine, due to this initiative, could bolster treatments for breast cancer. We already know that white women are slightly more likely to develop breast cancer than African American women, but for women under the age of 45, breast cancer is more common in African American women than white women overall. These factors, likely evident in our genetic code, are why advances in precision medicine are so very vital. And I know there are many studies, because I was part of initiating them years ago with Senator Al D'Amato, on environmental factors. That never led to very much, frankly. So if you could share with us what breakthroughs for breast cancer have we seen as a result of NIH-funded research, and how will the Precision Medicine Initiative improve the chances of finding a cure once and for all?
Thanks for the question. Breast cancer obviously is an area of major priority for the National Cancer Institute. The ability to be able to look at thousands of breast cancers and see exactly what is happening at the molecular level has taught us that this is not just one disease. This is many different diseases with different kinds of molecular pathways activated, comparing one person to the other. And those have already led us to new insights about kinds of therapies that we didn't know about. Obviously, the discovery of genes BRCA1 and BRCA2 that play a major role in hereditary susceptibility is part of that. But we have a longer list now of hereditary risk factors than I would have thought possible 20 years ago. But of course, what we really need is better means of prevention and early diagnosis and treatment. Put all of that together. Here's where I think, again, the Precision Medicine Initiative has a lot to offer. If, as we are claiming we can do starting next year, we could put together a cohort of 1 million or more individuals who are participants in a study that collects all of the data you could imagine about their medical experiences, about their DNA, about their environmental exposures, we might have sufficient power to really be able to get our hands on information that's been rather elusive about exactly what is the interaction between genes and environment that results in this disease or does not. Electronic health records now becoming the norm in many people's medical records is going to help that hugely. That's why this is the right time to initiate a program of this sort. We couldn't have probably done it 10 years ago, but now we can. Between electronic health records, environmental sensors, DNA analysis at an increasingly affordable cost, and the willingness of the public and the enthusiasm of the public to be part of a national effort of this sort, we could do something really groundbreaking and historic. And that's what this initiative aims to do for breast cancer and for many other diseases as well.
Well, I see the red light is on, Mr. Chairman, but I just have to tell you this is why our investments in the NIH are so critical. I find the information we gather here so very exciting, and I'm ready to double it again, as John Porter did. We could be groundbreaking here, Mr. Chairman. Thank you.
I'm very tough on the clock, except to my chairman and my ranking member of the full committee, so you take the time you need. Let me quickly, if I may, ask one question for myself, Dr. Collins. One of the areas I know concerns you, and certainly concerns me, is simply the pipeline of talented young scientists and researchers. And I recognize, and I think my colleagues have pointed out, when we are not as generous as we would all like to be in terms of our appropriations to this particular institute, you have fewer grants to reward to younger researchers, and the success rate of applicants goes down. This was really made aware of this recently by good friend of mine, Dr. Scorton, who's the president of Cornell, but the incoming president of the Smithsonian. And I asked him why in the world was he leaving a wonderful place like Cornell, this capstone job. Smithsonian's a great job. But actually the thing he said that concerned him in the future of science was exactly this. He said, I've got some brilliantly talented young people, and obviously they enjoy teaching, but they want to research. They want to get things done, and we're not giving them the opportunities that they need to have, and that's going to cost us down the road. So I'd like to know, number one, your assessment, but number two, what are the things that we ought to do? What are the things you're doing now to make sure that we engage the next generation of scientists that will hopefully match the accomplishments of this distinguished panel in their respective areas?
Mr. Chairman, thank you for the question. This is the issue that wakes me up at night when I try to contemplate the future of where biomedical research can go in the United States. We have such amazing scientific opportunities. Some of them I'm sure we will continue to discuss during this hearing. But yet our most critical resource is not pieces of equipment or buildings. It's the people, and particularly this next generation of researchers. They are full of ideas and vision, and yet they are finding themselves facing a situation that is the least supportive for that vision in 50 years. And they look ahead of them and see the more senior scientists struggling to keep their labs going and having rejection after rejection of grants that previously would have been supported, and they wonder, do we really want to sign up for that? And many of them, regrettably, are making the decision to walk away and to do something else. Meanwhile, the rest of the world, as has already been mentioned, is picking up steam, trying to be what America was 20 years ago, even as we seem to have lost some of our momentum, and that is going to have really significant trickle effects downstream. So what are we doing? Again, there's no real magic here to solving what is a very difficult equation of supply and demand, where the demand for resources to do research is not currently being matched by the supply. But we are trying to adjust many of the things that we can adjust, and I've had many interesting conversations with people on this subcommittee about this. One thing we're doing is to try to be sure that that first application from a new investigator gets a special effort to get funded beyond what would happen if they simply competed with people of larger experience. So new investigators, early stage investigators, compete against each other, not against the experienced ones. That gives them a bump in terms of their likelihood of getting funded. And many of the institutes actually on top of that give them an additional bump in terms of the likelihood of making the cut. That has helped to some degree. But of course, we don't want to set people up for that first award to be successful, and then when they come back for a renewal or the second award, we lose them because the edge is no longer there. We are doing a number of other things. We are funding a program that provides support for postdoctoral fellows who are ready to go on in a couple of years to an independent position, to compete for their award and then carry part of that award with them to an academic position, so-called K-99 awards. And we're increasing the number of those because that does seem to be a good mechanism. And a number of other things are being done to try to free up more of the proportion of funds for more applicants. I'm going to quickly ask Dr. Lorsch, who's the director of the National Institute of General Medical Sciences and is a major part of, therefore, of our training initiatives, to say something about some of the ideas they're pursuing.
So thank you, Dr. Collins, and thanks for the question, Chairman Cole. This is an area that we are very concerned about, as are you. We are starting a new pilot program called the Maximizing Investigators Research Award, which has as its fundamental goal to improve the efficiency of our funding mechanism, which would increase our ability to distribute funds, especially to young investigators. It would also have several other targets. One would be to improve the stability of funding for these investigators, because if they're constantly at risk of losing their funding, clearly that's not an ideal situation. It would improve the flexibility for investigators to follow new research questions as they arise. And we think it would improve their ability to take on ambitious research projects and follow them in a creative manner. But efficiency, I think, is the key.
Thank you very much. I want to move next to my friend, the ranking member from Connecticut.
Thank you, Mr. Chairman, and thank all of you. Mrs. Lowy and I just briefly talked to each other about the level of discussion at the hearings with the NIH are inspiring. The intellectual pursuit, the science, gives you, and that the United States is on the cutting edge of these efforts, gives us such a sense of pride. But more than that, again, it is what you are doing to push the edge of the envelope in so many directions in terms of saving lives. And that leads us to, we were both on the committee, Mr. Chairman, when we doubled the amount of money for the NIH along with Mr. Porter, and it was so genuinely bipartisan. If there is an area in which we can come together and understand the value of what we have here, that I think it would serve us well to think through what we should do for the future. I'm going to address an issue that you know has been of interest to me for a while, and I know it's for my colleague, Mrs. Lowy, as well, and that is the gender balance in preclinical research. We've worked to make sure that women were represented among the subjects of biomedical research, including in the preclinical research studies. I don't have to tell you that men and women differ in their responses to medical treatments, and oftentimes using the models that rely exclusively on male animals can lead to serious harm. Women experience higher rates of adverse drug reactions than men do, for example. Dr. Collins, in May of 2014, you co-authored an article in Nature with Dr. Janine Clayton, Director of the Office of Research on Women's Health. You announced that NIH would require applicants to report their plans for the balance of male and female cells in animals in preclinical studies in all future applications. And that's the quote. You noted that the new policy would be rolled out in phases beginning in October of 2014. Dr. Clayton noted that, quote, the exception will truly be the exception, not the rule, end quote. Let me just give you the 2 or 3 questions I have in this regard. And if you can give us an update on NIH's new policy to require that both sexes be represented in preclinical research. What kinds of responses have you received from the research community? Are you seeing an immediate impact in applications for funding in fiscal year 2015? Will you consider requiring the analysis of data by sex and other subgroup demographics as part of grant progress reporting? What are you doing to encourage journal editors to require an analysis of results by sex? How are you holding institute directors accountable for funding studies on sex differences and conditions that predominantly impact women? How are the institute directors accountable for partnering with the Office of Research on Women's Health on studies? And can we expect all future NIH-funded research to include both sexes unless there is a specific reason not to include them, such as the focus on ovarian cancer or prostate cancer? A lot of questions, I know, Dr. Collins, but I think it's imperative this moment because you are moving and we need to make sure that we get all of this as we move forward. I know we worked in the past and some things have not moved forward, and now I think is an opportunity for us to address the issue again.
Ms. Lowy, Ms. Delora, I appreciate the question and appreciate your leadership in bringing this to the attention of the public, and certainly I can assure you of my strong personal commitment to addressing this issue as was documented in that article that you mentioned that I wrote with Dr. Clayton in Nature. The update is we have now had extensive conversations with all of the institute directors and with the scientific community, and including at my advisory committee to the director, which is my most senior advisory group, about this issue. And I think there is generally broad embrace for the need in preclinical studies. On the negative side have mostly reflected anxieties about whether this would mean now that every study that previously studied only male mice, for instance, now has to be doubled in size in order to study males and females, and that will cost more and it will result in fewer studies being done. I think that is a unnecessarily negative response to this question. The idea that you should include males and females seems really compelling. The idea you should analyze the data separately is really compelling. You will have to decide in every study how subtle a difference between the sexes are you willing to miss, because that will determine how big your study has to be. But we know how to do that. That's called power analysis, and it can be applied in this situation quite handily. The institute directors, I think, are in the process now of finalizing their approval of the way in which we are going to implement this for NIH grantees, and with much community input. So I can assure you, this will be something which is not left neglected. We will have definitive guidelines for all grantees who are doing these kinds of studies about what their expectations are. For reviewers who review these studies, it will be made very clear that that is part of how you are to review a grant that comes to NIH. Journal editors have been in conversation with us, and we've had great interactions with them about the general area of reproducibility, and this fits within that. If you have two studies that don't get the same answer, but one studied males and one studied females, that's not called lack of reproducibility. That's called interesting new data that you'd want to follow up on. So they're in this mix as well. I think it's fair to say that the NIH is across the board fully committed to making these things happen, and it's time. It's overtime.
Thank you for letting me go over time.
Absolutely, thank you. I want to go next to my good friend from Idaho, distinguished member.
Thank you, Mr. Chairman. And Dr. Collins and all of the other directors, thank you for being here today. The bipartisan nature of this subject with this committee is pretty obvious and has been in the past, and that's good. It would be, I think, the desire of everyone on this committee to substantially increase the research we're doing if we didn't have an $18 trillion deficit and or debt and a $500 billion deficit that we're having to deal with at the same time, which makes it more difficult. But still, it's something that we put priority on and try to do in a bipartisan manner. I would like to ask you a whole bunch of different questions, but I'm going to come out and visit with you for a day and take a tour of some of the different institutes and what goes on there, and so we can get down and have some real good discussions. But there is a couple of things. This personalized medicine that you're talking about, or precision medicine, is fascinating to me. And I understand that Omnics is the collective use of technologies such as genomics and protein medics, or something like that, that explore how cells and organisms are made up. As NIH, and I understand in your testimony you said you're going to concentrate on cancer right now. Obviously, it's lethal disease and so forth. Is there any plans to look at broader, maybe not as lethal diseases or not as serious diseases and the effects that personalized medicine could have in the research in those arenas?
Absolutely. Again, let me maybe be more clear than I was. The Precision Medicine Initiative has two components: an early focus on cancer, because this is so ready for this kind of really expanded effort to understand what causes cancer, what we can do about it. But the other component, which is a long-term, ambitious to be sure effort, is this cohort of 1 million or more Americans, which we could be studying for virtually all diseases. And knowing that you are a dentist, I would certainly include in that such things as periodontal disease, dental caries. We know there's an environment and genetic risk involved in those conditions, but we haven't really had a sufficiently large study with appropriate patient participation to be able to get those answers. This should be a way to go there. So that's true for diabetes, for heart disease, for Alzheimer's disease, for virtually every common condition. With 1 million people, you're going to have enough events that you should really begin able to dissect what were the biomarkers that warned this might happen, what were the environmental factors that played a role. We haven't had that kind of power before. We aim to get it.
That's fascinating stuff, and could really advance the treatment of diseases and the cure of diseases. I'm going to submit some questions for the record, but the one I did want to ask is, in our conversations in the past, you've indicated your strong support for the National Center for Advanced Translational Sciences, known as NCATS. I heard from some advocacy groups several years ago who expressed concern that putting more resources into NCATS might come at the expense of research. And I don't believe that to be the case, but you do request a $27 million increase for NCATS in FY16. Can you update me on how things are going with NCATS and some of the benefits we've seen from this new center?
I'm happy to. So NCATS, now just 3 years old, was the first new center at NIH in quite a long time, and was focused in trying to identify what are the bottlenecks in going from basic science discoveries to clinical benefits that NIH could address in collaboration with our partners in the private sector. I think initially there were some concerns that NIH is becoming a drug company. That really was never the plan and is not happening now. Instead, we are identifying areas of technology development that no single company could undertake, but working with them we can. Give you just one example. The effort to try to figure out when you're developing a new drug whether it's going to be safe in humans or not has been a real difficult one. We use animal studies, small animals, large animals. It's not that accurate, it's slow, it's expensive. We probably lose drugs along the way because some mouse got a slight liver issue and it probably would have had no relevance to humans, but we sort of lose the drug at that point. Wouldn't it be better to be able to test toxicity against human cells, but not put humans at risk? Now with the ability to create from a skin biopsy from you or me, basically cells that represent liver or heart or brain or kidney or muscle, on a three-dimensional biochip, we can begin to do those experiments without putting people at risk and get very interesting data about what drugs are likely to be safe or not at a much lower cost. We're doing this with FDA and DARPA. It's now 3 years along. NCATS, though, is the place where this lives, and it's a very appropriate thing. And pharmaceutical companies are wildly interested in this because if it works, it could greatly improve the likelihood of knowing whether something is safe before you get into that expensive clinical trial. I could go on with many other things that NCATS is doing. They're all quite innovative. They would not have probably happened without NIH stepping into this space. We have high hopes. They're high risk, but I think they're going to be high reward. The other thing that's in NCATS now is all the CTSAs, the Clinical Translational Science Centers, which are present in many of your states, which is our network of 62 academically based centers that is where an awful lot of clinical research is being done.
Thank you all. Thanks for the work that you do, and look forward to coming out and visit with you. And as I've said many years, and I'll continue to say it, NIH is, for good and bad, the best-kept secret in Washington, D.C., and the American people need to know what happens out there. Thank you.
Love to host you. Please come out.
Thank you. All of us on this committee know that our good friend, the gentlelady from California, Ms. Lee, has been dealing with a difficult personal situation with the loss of her mother, and she's been in our thoughts and prayers, and it's wonderful to have you back here with us today. So the gentlelady's recognized.
Thank you, Mr. Chairman. Let me thank all of you, and you, Mr. Chairman, for your condolences and your support and your real expressions of sympathy during this very difficult period. My mother, and I'm so glad to see everyone here today, and I want to thank all of you for your work, for your efforts really to save lives and to ensure the quality of life for everybody in our country. My mother was 90 years old. She died of COPD, which is the third largest death by disease in this country. And I've spent many a night and many a day in emergency rooms and hospitals, but because of you and the work of NIH, she lived to be 90. She lived with COPD. And my sister has multiple sclerosis. And again, because of you, this work in this committee, my sister's 67 years old, and she's leading a very healthy life as a result of NIH and the research and the treatment. So I have to personally thank you all so much for the work that you do. And of course, I want to see your budget doubled so that everybody can, first of all, be free of these diseases. And I wanted to ask you a couple questions with regard to COPD research in terms of prevention and new treatments. Also with regard to multiple sclerosis and your brain initiative, how that will impact people with MS, sickle cell. You know, I've been working for many years now on looking at the A1C test as it relates to diabetes and the correlation between sickle cell trait and diabetes and the A1C test, and see how that our doctors and labs fully aware now that that could give a false positive, and what you're doing around that in terms of the research. Also, just in terms of your budget as it relates to HIV and AIDS, I'm really pleased to see the increase. Want to see if you're coming up or we're close to a vaccine, what types of new treatments do you envision with this increase of $52 million? And finally, just as it relates to the National Institute on Minority Health and Disparities, really pleased once again to see an increase of $14 million in funding. and want to look at how you're focusing on or looking at social determinants of healthcare, because we know many of the health disparities in minority communities directly relate to the social determinants and how this is being framed and researched within the NIH. So once again, personally, I just have to thank all of you. Thank you very much, Mr. Chairman and members, for your support during this period.
Well, Ms. Lee, those are great questions, and maybe if
Listen, I'm going back to medical school now, as a result of my family.
Sure. Maybe I'll ask Dr. Gibbons first to say something about COPD, and then we'll try to work through as many of these as we can.
Sure. As you mentioned, chronic obstructive pulmonary disease is the third leading cause of death in this country, one in which the NHLBI has provided clinical trials that have provided a better course of life, particularly the nocturnal oxygen trial. But we need to do more. The challenge is that we often diagnose and treat that disease toward the latter stages when a lot of the damage has already been done to the lung and it's primarily supportive. This is really an opportunity, in fact, for precision medicine where we can diagnose and start to develop interventions earlier in the course to really prevent a lot of that deterioration that occurs. We're excited about the opportunities that come from genomic medicine, where we're starting to understand the pathways that are promoting that inexorable progression of disease toward death. And we have some exciting opportunities to develop some new therapeutics in that regard, which is very exciting.
And maybe I'll ask Dr. Fauci to say something about a new trial in multiple sclerosis, which his institute supported, and while he has the microphone, say something about HIV/AIDS.
Thank you, Francis. Thank you, Mrs. Lee, for this question. As you're probably aware, just a few weeks ago, there was published a very exciting study, really one of the most important studies we've seen in multiple sclerosis, in which 25 subjects were involved in a phase 2 open-label study of stem cell transplantation in individuals who had rapidly aggressive, progressive multiple sclerosis, who you would expect by historical control over a period of months would continue to deteriorate. The study was a resounding success. Greater than 80% of the individuals survived without any progression for a period of up to 3 years, which is really quite unprecedented. Now, it's an open-label study that was not controlled in the classic sense, but the historical control is so compelling because when you get those patients, they almost invariably progress, and these patients did not. So we're very excited about it, and we're going to move on to the next phase of the study. So I would say of all of the things that we've been doing with multiple sclerosis over the last several years, in my mind, this is the most exciting. So that's the multiple sclerosis issue. You asked about HIV. There's so many aspects of HIV, as you well know, throughout the world and including in this country. We're seeing several countries taking that tipping point where the number of new infections are less than the number of people who are going on to therapy, to the point where we're starting to see a deflection in the curve. The thing that would nail it really down with regard to prevention and the treatment as prevention programs that you're very familiar with, in which you can decrease by 96% transmissibility from an infected to an uninfected person by, in fact, treating them and getting their viral load to below detectable level. There have been several studies that came out at the CROI meeting in Seattle last week that showed that pre-exposure prophylaxis of individuals at high risk, particularly men who have sex with men, superimposed upon treatment as prevention, has provided a substantial decrease in infection rate in certain areas. And finally, in the vaccine issue, there are two major parallel pathways that are being pursued. One is a pursuing of the follow-up of that very exciting, though modestly successful, Thai trial from several years ago that I reported to this committee, the RV144, that was 31% effective. Not enough for prime time, but enough to give us some insight into the next stage of what we're going to pursue. We started a trial in Africa, and it looks like the response in Africans is quite similar to those in the Thais, which means that that is a glimmer of potential success in the African trial. And then there's a whole bunch of research that is led by our Vaccine Research Center at the NIH, as well as a number of centers throughout the world, on looking at the ability to induce broadly neutralizing antibodies, which are difficult to induce with natural infection, but we're making headway in being able to induce them with the right immunogens. Thank you.
Thank you. Dr. Collins, you can see your colleagues may be brilliant, but mine are very crafty at loading up questions, but they're great questions. They're great questions, and the chair is going to be as generous as he can with the clock. So with that, I'm going to move to my good friend, distinguished member from Arkansas, Mr. Womack.
I'll try to be quick. I know I'll use my time. I've got 2 or 3 questions, but and I too was one of the people that went up on the tour, and thank you. I'm in awe of the presentation that's being made here today, just as I was the day when we toured the National Institutes of Health, and I'm grateful that that you guys are doing, the guys and gals are doing the great work you're doing. I'm going to follow up on a question from the overall chairman from earlier. When you said you need to make sure patients can access new medications and treatments coming out of the NIH to combat prescription drug abuse, I completely agree with that. But right now, SAMHSA's regulations for medication therapy for opioid addiction prevent this and only push 2 medications, buprenorphine and methadone. Can you follow up on what the NIH is doing to make sure patients can access these medications? Are you working with other agencies such as SAMHSA to ensure they aren't detracting from, but instead complementing the efforts of the NIH?
Yes, indeed. Thanks very much for your question. And for us to succeed, we have to work in partnership with our sister agency, SAMHSA. So we have mechanisms by which we actually bring together the researchers and the clinicians to ensure that developments, in this case in the area of medications for opioid addiction, are implemented in the treatment setting. Having said that, there are always problems in terms of ensuring that patients have access to these medications, and that's why I had made the point before, including the need to ensure that the insurances will be covering and providing access to them. There's a third medication that is also available, Vivitrol, which was also developed through the NIH with very good outcomes, and as of now, we know that not only are these medications effective in treating substance abuse, they are effective in preventing overdoses, and they are effective in preventing HIV. So they work. We need to implement them.
Dr. Collins, you would expect that I'm going to have a question about IDEA funding because Arkansas is one of those states that benefits. We have a lot of underserved population, and I know a lot of our applications go wanting, and we would like to improve that. We are pretty much a rural state. Places like Dermont, Arkansas, Dr. Gibbons. In your FY16 budget, you ask for a 3% increase over FY15. However, the budget requests level funding of $273 million for the IDEA program. I'd like to know why the program that helps states like mine, the other 22 states that help secure this funding, are not prioritized. Can you kind of walk me through that process?
Well, NIH is a big fan of the IDEA program and appreciate your question. Certainly the things that have been accomplished through this program in states like Arkansas are truly exciting, a great opportunity for research and for training. In terms of the budget issue, there was a $50 million increment that the IDEA program received in 2011, which means that it actually over a 5-year period has grown more rapidly than the rest of NIH. This particular year, it did not change in its total dollars, but over that 5-year period, IDEA has been doing pretty well. I do want to ask Dr. Lorsch, because IDEA is now managed in NIGMS, to say something about this program, which I know he is also quite enthusiastic about.
Thank you very much, Mr. Womack, for this question. As Dr. Collins said, the IDEA program is now housed at NIGMS, and we're very proud to have it there and are completely committed to the goals of the program. I think the key is that whatever the budget, we're going to do whatever we can to make sure that those goals, that is increasing the geographic distribution, ensuring that all 50 states in the union have cutting-edge biomedical research going on, are met. I recently traveled to Arkansas, to Little Rock, and saw some of the amazing research that's going on there and in the southeast region of ID, including in your district, University of Arkansas. We have a COBRE Center there, Center of Biomedical Research Excellence, that's focusing on determining the three-dimensional structures of proteins from viruses and bacteria, and using that information to try to develop drugs to treat a variety of different diseases. And so what I can assure you is that we will continue to push the goals of this program forward as best we can.
I know I'm out of time. We'll submit other questions for the record. Let me just finish by saying this, that as I said in my opening, I am grateful for the work that's being done by this agency, and it's gives me a great deal of pleasure to be associated with a panel of experts like we have here before us. Mr. Chairman, I yield back.
Thank you, Mr. Womack. Next, we go to my good friend from Pennsylvania, Mr. Fattah.
Thank you, Mr. Chairman, and let me thank the panel. Let me ask first about the Joint Programming Neurodegenerative Disease Initiative the EU has created, and they have participation from Canada and Israel. I know there have been some discussions about American participation. Could you tell the committee whether we plan on engaging in terms of broader clinical trials on degenerative diseases through JPEN?
So, Mr. Fattah, really appreciate your strong leadership in the area of neuroscience. I'm going to ask Dr. Insel, who's co-lead on our BRAIN initiative and also a major figure in neuroscience at NIH, to respond to your question.
Well, thanks very much, and thanks for all you're doing in this area. The JPND, this is the joint program that you talked about, is really an EU program. They've reached out to us, and what's evolved more recently is something that's going to be sitting under the G7 authority around dementia more specifically. That's really the piece that we've become most involved with. So we do have a series of joint meetings. There, I suspect, will be some joint initiatives. That hasn't happened yet, but that's very much in the discussion, and we're looking forward to working closely with the other G7 partners around the dementia efforts.
Well, thank you very much. I know that Prime Minister Cameron initiated that. I met with Dr. Gillings from the World Dementia Council. But I would like to get a particular review of whether the JPEN program is something we are or we're not going to join. And so you can provide that at some later
We'll get
date.
that for the record.
Let me ask a question right in your alley while I have you. In the omnibus, we put some additional dollars in for the Samson mental health block grants and directed that Samson work with your institute to help states implement programs that are proven effective in terms of preventing the first episode of psychosis. So I understand that in this way, research findings from your institute have become to be called RISE, Recovery After the Initial Schizophrenic Episode, and are being readily applied in communities so that patients are benefiting quickly from research findings. Could you tell us where we are right now and what the future holds?
Sure, thanks for that question. The RAISE program, the Recovery After Initial Schizophrenia Episode, is a program that has been going on, actually originally really bolstered by the ERA funding from 2009, 2010. The study was completed in terms of its feasibility only in December of 2013, and this committee saw fit in soon thereafter, at the January of 2014, to ask SAMHSA to implement the findings of that study in all 50 states. So it's almost an extraordinary story of science to service or science to practice. Usually it takes longer than 6 weeks, but in this case, it happened in 2014. There are pilot programs that were developed in collaboration between NIMH and SAMHSA in all 50 states. We're watching that now as it continues to grow in 2015. What we'd like to do now is to build on that in a very specific way. We want to be able to create a sort of learning healthcare system out of these kinds of programs that would be really not so much research to practice, but now practice to research, learning from the experience in where the care is being delivered, how to improve outcomes for people who have a first episode, and most importantly, how to prevent that first episode. So we're trying to actually move earlier in the cycle to make sure we reduce the number.
This has a great potential of preventing some of the tragedies we've seen around the country, and I know the committee will have a continuing interest as we go forward. Let me go 30,000 feet up in the air. I know you co-chaired the interagency working group which I established through language in the Commerce Justice Science bill, where I'm the ranking member. Here I'm in the junior chair, but the fact that I could just be in the same room with Tom Cole, I'm happy.
The gentleman's
you
request will be-
co-chaired the working group, and the BRAIN initiative is a major inspiration thereof, but there are a number of other things in terms of imaging, in terms of the pharmaceutical industry. I know that Dr. Collins, you've launched the Accelerated Pharmaceutical Partnership, and there's just a lot of things that are germinating. If you could help us understand the budget requests, Dr. Collins or Dr. Insel, in terms of the BRAIN initiative this year, and how those dollars will be meaningful in terms of you moving forward, that would be helpful. Thank you.
Sure, I'll take that on. I should say at the beginning that every time I go anywhere, I find out that Congressman Fattah has just been there, Stanford, MIT, you name it, and every neuroscience lab you seem to have. I suspect you'll get an honorary Ph.D. here pretty soon in neuroscience. The BRAIN initiative is, when it was first set up, we asked a group, or Dr. Collins asked a group of experts to sit down with us and to give us the best idea of how to develop this. And they created this 10-year plan, which is called BRAIN 2025. And in that, there is a budget. And the budget will grow to roughly $500 million a year by 2019, and will ultimately, over 12 years, be about $4.5 billion, very much like the Human Genome Project. We're not there. Right, so we're just in we're 2015, we're at 80, we'll be around $80 million with the President's request next year of another $70 million that'll take us up. But I have to say that the question that gets asked for us over and over again, seeing how spectacular the scientific opportunities are, people say, they look at that report and they say, you've got a great roadmap, but is there any gas in the car? People are really concerned in the community that we have this opportunity that's unprecedented that may be underfunded. So we're hoping that with the funds that we've got now, that we'll be able to do 10 RFAs this year. We did 58 projects last year. We'd like to have another 50 or so come out this year, but going forward, whether we'll be able to build this in the way that we had originally envisioned is going to depend a lot on your support.
Thank you, Mr. Chairman. There are tens of millions of Americans counting on your work in this regard. I thank the Chairman.
The gentleman's gracious compliment got him extra time. It may not get him extra money, but we'll see about that. We'll next go to my good friend, the gentleman from Tennessee, Mr. Flashman.
Thank you, Mr. Chairman, and Dr. Collins, and to all the directors. I just want to say thank you. You all fight the maladies that face so many millions of Americans, and your research and your commitment to medicine and science is incredible. So I thank you very much. As you all know, I have been a very vocal, outspoken advocate with the fight against cancer. Lost both my parents to cancer, my mother when I was very young. And I thank you for all your endeavors in that regard. But one of the particular sad things about cancer is children with cancer. And my question today, and I hope you can help me, a little boy came to see me. He was blind. He had a brain tumor, and he and his dad came to see me and sat with me. I was not even his congressman. I believe he lives in Maryland or Virginia, but I sat with him and I spoke with him about his cancer. So I hope you can help me with this. Pediatric low-grade astrocytoma is a slow-growing children's brain cancer that impacts over 20,000 children every year, and there's over 1,000 new cases apparently diagnosed every year. Existing treatments for PLGA brain cancer are invasive, highly toxic, and so far relatively ineffective. The treatments themselves can cause serious permanent damage and are often life-threatening. What research is being currently conducted by the NIH on PLGA? What treatments and therapeutic alternatives are on the horizon for PLGA patients? And are there any clinical trials currently being conducted by NIH for PLGA? I'd really like to respond back to this little boy.
Well, thank you for the question. Dr. Varmus, who's the director of the NCI, is currently out of the country, or he would be here and I'm sure would be answering your question, but I'll see what I can do. I agree with you. PLGA is one of those pediatric cancers that we desperately need better answers for. That it is slow growing, it doesn't respond particularly well to the kinds of approaches that attack cancers that are growing rapidly and that have made so many advances possible in pediatric cancers of other types. Clearly, there's a connection here between what we were discussing a little bit ago in terms of the cancer focus of the Precision Medicine Initiative. And as part of that, the Cancer Institute aims to enroll something like 1,000 pediatric patients in this earlier stage of trying to understand what drives malignancy. And I would be very surprised if some of those are not, in fact, PLGA patients, to try to understand more about the disease. Obviously, one of the really difficult problems is access to tissue here, because it's not an easy thing to imagine just doing a biopsy of a tumor growing in such a vulnerable place. But there are potential ways that one can begin to look at that actually by looking at DNA that's floating around freely in the blood circulation. We're learning that cancers, because they do turn over, release their DNA. And one can discover it by looking in the circulation for free DNA that's not inside a cell. And in a cancer, that may tell you what's going on without having to do a needle biopsy, this so-called a liquid biopsy. That would be one area of focus. In terms of clinical trials for PLGA, I do not know right off the top of my head what's there. I'm sure if I was looking, I'd go to clinicaltrials.gov and see what's listed. I can certainly get for you, for the record, an indication of what kinds of trials are not only going on, but what might be planned for this terribly difficult condition. And we share your concern about needing better answers for that boy who came to see you.
Thank you, Doctor. I believe I have some additional time, so I'll ask a follow-up question on something else.
Please.
Our country prides itself on being at the forefront of research and development, and biomedical research is no exception. You've expressed some concern about the amount of money going towards international research. Could you please share with us why, with a budget the size of NIH's, you have these concerns, and let us know, in an effort to maintain American competitiveness while working to make the largest strides possible to finding cures for the diseases that have the greatest impact on our population, what are you doing to take advantage of the research being done in other countries?
It's a great question. Science is an international effort, and certainly many major programs, including the Human Genome Project that I had the privilege of leading, was international. 6 countries were involved in that, and all the data was made immediately accessible. But it's very clear that the country that leads in biomedical research enjoys other benefits rather directly, especially in terms of commercial spin-offs, and those are wonderful ways to create jobs. America's leadership has led to the fact that we are not only great in academic biomedical research, we also have the most vibrant community of small businesses, biotech companies, and pharmaceutical companies. We would not want to lose that benefit. And yet, when you look at the trajectory that our funding is on compared to other countries, there are deep concerns. We've lost at the NIH about 22% of our purchasing power for biomedical research since 2003, a very substantial downturn in terms of what we can support. And other countries, on the other hand, are going the other way, China in particular, increasing their support of biomedical research by 20% per year over multiple years. The consequences of that, I would refer you to an article by economist Hamilton Moses in JAMA, which was just published about a month ago, has a lot of data in it, pointing out a number of things that are quite alarming if you really care about the U.S. maintaining that leadership, including the fact that China is now filing more patents in biomedicine than the U.S., not just as a proportion of their GDP, but absolutely more patents. And the consequences, I think you can imagine, are going to be significant. The final conclusion of this article, and I think this is a distinguished group that wrote this, is given international trends, the United States will relinquish its historical international lead in biomedical research in the next decade unless certain measures are undertaken. They see the pathway and they don't like what's happening. We can turn this around. What NIH desperately needs, and what would be such an inspirational moment for our community, especially those early stage investigators we were talking about, is a sense of stable trajectory, that we have the chance to be able to plan, to take risks, to do innovative research without the uncertainty about what will happen one year or the next. Maybe a doubling would be actually a nice thing, but what would be even better would be an opportunity to see a path forward that keeps up with inflation, plus a little bit, and that we could count on, and that people could basically then flex their innovative muscles and take advantage of this amazing talent that we have in this country.
Thank you, Dr. Collins and everyone. And Chairman, I yield back.
Thank you very much. Now move to recognize my good friend, gentlelady from California, Ms. Rybal Allen.
Okay, thank you, Mr. Chairman. And first of all, let me just associate myself with the comments that were made by my colleagues about the tremendous work that you all do, and what a positive impact it's had on the quality of life of so many people, not just in this country, but throughout the world. But I do have some concerns that I would like to address. Dr. Collins, in 2000, this Congress authorized the National Children's Study to investigate how the environment influences a child's development and health. And over the last 15 years, Congress has appropriated over $1.5 billion to plan and pilot this study. Given the huge investment, Congress fully expected that the study would be carried through to its completion. And in fact, in almost every fiscal appropriations report from the year 2000 to 2014, there have been specific instructions from both the House and Senate directing the continuation of the study. And in March of 2013, Congress requested a review of the revised study designed by the Institute of Medicine. And the IOM concluded that there were conceptual, I'm having trouble with that word, you know what I'm trying to say, right? And administrative challenges that must be addressed, but that the NCS still offered, and these are their words, enormous potential. The IOM also concluded that when the study was completed, it would, and again I'm quoting, add immeasurably to what we know about children's health in the United States. So after reading the IOM summary report and given the $1.5 billion that has been sent, I was frankly very, very surprised by your announcement canceling the National Children's Study. And I'm sure I'm not alone in believing that a better outcome for the $1.5 billion investment should be at least a completed study. So my question is by what authority did you use to disband this study whose authorization is still in current law, and for which Congress has spent $1.5 billion over the last 15 years, and for which this committee in FY15 in the omnibus bill put in language that said, and I quote, "The NIH Director is expected to use this framework," meaning the framework coming out of the IOM report, "to ensure the mission and goals of the NCS are realized to generate the anticipated returns from the years of taxpayer support." So I just would like an explanation as to what happened here.
Well, I appreciate the question, and this has been one of the more difficult decisions since I've been NIH Director over the last almost 6 years. The National Children's Study was designed in various pieces over quite a long period of time. And I think as that time passed, some of the design issues in retrospect maybe were not serving the need of getting the information which we all agreed was crucial, that is to understand environmental impact, factors that occur both during pregnancy and beyond that influence child health. We all agree those answers need to be found. The problem that increasingly seemed clear was that the design of the children's study, which carried with it a certain historical legacy, was not fitting with the way in which technology was developing over the course of the last almost 20 years. The IOM study that you mentioned was in fact quite critical about those issues and about administrative issues, and because of that I asked a working group of my advisory committee to look closely at all of the aspects of the children's study and to make a recommendation to me about whether it was still feasible. They came back and said, frankly, they did not believe that it was, and that it was more responsible at this point to try to make sure that what the data that had been collected through the Vanguard studies, which were the pilots for the children's study, were made available and kept in place for those who could learn from it. But that we really ought to think about coming up with a new strategy to get answers to these same questions. The Congress in the omnibus bill basically gave us the opportunity to take the $165 million that's in the FY15 budget and think of new ways that we could in fact obtain answers to these questions about environment and pediatric health. And we have been vigorously engaged in that effort over the course of the last 2 months, and will in the very near future announce what the programs will be in FY15, which I think you will find to be quite innovative. I believe the silver lining here is that this gives us a chance to step back from the legacy of the last 14 or 15 years and say, okay, now in 2015, with all the technology that's advanced in the interim, what could we do that would get better answers, perhaps for less cost than what was originally contemplated for a 21-year study? So look at the next things we put forward. We're quite excited about it. The institutes have all gotten very engaged in this opportunity to rethink this. And ultimately, I think we will get to where we need to be, but in a different way than was imagined back in 2000.
Okay, because it's my understanding, according to a Bloomberg Business report, that Dean Baker, who was a researcher at the University of California, Irving, who ran a pilot and was one of the lead investigators of the study, said that the IOM report that, and I quote, that they did not conclude that the enterprise was beyond saving, and that was a decision by NIH. And we know a study of this nature is feasible and even identified a pathway. So that was a decision that was made by NIH, not based on the outcome of the IOM report. So just very quickly, I know my time is up, but what is the period of time and the amount of funding now that would be needed for NIH to address the recommendations that were made in June?
I would ask the gentleman to
and to develop a plan. If you could do that for the record.
Or if you care to make a quick comment,
very
please
quickly,
do.
just in terms of the process, if you read Chapter 5 and Chapter 6 of the IOM report, not always well reflected in the executive summary, it's actually very critical of some aspects of the study. My advisory group, led by Phil Pizzo, former dean at Stanford and a pediatrician, and Russ Altman, a distinguished epidemiologist and computer scientist, came to a very strong and unanimous conclusion that the children's study was no longer feasible. I had to accept their conclusions because they were so well-founded. In terms of where we go, please look at the next proposals, which will be coming forward very shortly, about how we will address these issues. We do have a lot of things to talk about, though, I think, in terms of going forward. Where should this kind of research go in the out years? And we need to have that conversation.
I'd like to follow up, and thank you, Mr. Chairman.
You're welcome. Now I want to go to the one member on our team up here that might actually have the intellectual firepower to stay with your team down there, Dr. Collins. Recognize Dr. Harris.
Thank you very much, Mr. Chairman, and thank you all for coming and appearing. First, I'm just going to start with a rhetorical question first. Since the last time you before this committee, you probably know my wife passed away from heart disease 3 days before her 58th birthday. As you also know, the NIH and in general, we've really underfunded research into heart disease on women over the years. So I went back and looked at the chart of, what by disease breakdown, what the NIH spends on. 84 million Americans have heart disease, and yet the amount we spend per death is 100 times less on heart disease than it is on HIV/AIDS. 100 times less per death. That kind of discrepancy just needs to be justified, and it's just going to be a rhetorical question. I mean, it is stunning what that discrepancy is and how the fact that we dedicate as little as we do to heart disease, the most prevalent disease in the country, how that will affect the population. Anyway, rhetorical question on that one. Dr. Volkow, I'm going to ask you a question about drug use. There's obviously ongoing discussion about legalizing a dangerous addictive drug called marijuana. Some people may not think it's dangerous or addictive. It is dangerous or addictive. It affects the human brain, including memory, motivation, a lot of things that are probably not good for people, especially our youth. Do you know what the economic impact of marijuana use is, including its effect on workforce preparedness, on education? Do we have these answers? Are these important things to study, and do you have the resources to study these things before we go willy-nilly into just legalizing a dangerous addictive drug?
Dr. Harris, thanks very much for your question. And indeed, there's been many studies that have evaluated specifically the consequences of use of marijuana among teenagers vis-a-vis their educational achievement. And they have consistently shown that it actually decreases, if you are smoking marijuana in adolescence, it decreases the likelihood that you will finish school and that you will get a degree. With respect to what is the impact in the workforce, the data there is much less clear. The studies have not been done as extensively as for education. We know in general that the use of drugs in the workforce is responsible for 30% less productivity on an individual that takes drugs, but that has not been distinguished with respect to see whether it's marijuana or cocaine or methamphetamine. So we really do not have a precise number there.
Sure. And just as a very quick follow-up, you'd imagine that since marijuana actually affects motivation, something that might be important when you go to work, you'd imagine it might actually have quite an influence on workforce, wouldn't you?
Yeah, I would predict so, and what is shown is the contributions of the decrease in productivity are absenteeism, not showing, but when you are there, presenteeism, you are there, but you are not really working. And the same, the lack of motivation may account for the very poor outcomes in education.
And we should probably answer these questions before we go on. I mean, we should expect scientific answers, I imagine.
I completely
Rhetorical
agree.
Question. Dr. Collins, let me follow up with you again about some things that are being said about internationally what's going on and what's going on in our biomedical workforce. Again, 50,000-foot view, because, you know, I think you actually sent you sent something around with your article in JAMA, I guess in January of this year, you know, suggesting that perhaps, well, China, you know, will actually overcome the United States in 2022, which, yeah, I guess if you look statistically and you assume, you know, exponential growth continuing, things like that. But what's interesting is the growth in China is actually in the private investment, the industry investment. There's a little bit of growth in the public investment, but the real growth's in the private industry. And as you also noted, one worrisome trend in the United States is that the industry investment in biomedical has gone down. That's not your, you know, that's not where you have the ability to directly impact. Maybe you don't. But I think that that's an important key in this that we're not talking about. And, you know, there are certain policies that do impact that. For instance, you know, we're undergoing a TPP negotiation where patent protection of American manufactured biologics actually will be hindered. That doesn't help our biomedical industry here. When we're negotiating a trade treaty that actually will hurt our biomedical industry because of the nature of biologics. What's the strategy? Because we can go on ad infinitum. You know, one interesting thing is, you know, the administration, in spending $35 billion additional dollars we don't have on non-discretionary spending, decided to send only $1 billion to the NIH, only a 3% increase. I think that's a drop in the bucket if we don't get the picture of the larger picture of the entire biomedical research effort in the United States. So what can we do, or what can you do, at the NIH to implement a strategy where we can promote industry investment? So you have partners in industry. So we're leveraging NIH dollars, greatly leveraging them, as it appears China is doing.
Again, to be fair, try to be brief, and I would remind the questioners, let's not jam them right up against the end of the time and then leave them hanging. That's a tough position to put our guests in.
Well, very quickly, I agree that we have a responsibility and an opportunity to bring together the public and the private sector investments in biomedical research like never before. One example is this Accelerated Medicines Partnership that I spent 3 years working with a number of heads of R&D in big pharmaceutical companies, particularly Michael Dolston at Pfizer, to put together, and which is now, with shared expenses being covered 50-50 by the private and public sectors, doing something never attempted before for Alzheimer's disease, for diabetes, for rheumatoid arthritis and lupus, putting the scientists around the same table, designing the experiments, holding themselves accountable with milestones, and making all the data accessible to others who might have good ideas about it. This is unprecedented, what AMP is trying to do. We're 1 year into this. We're ahead of schedule. I'm looking for all those opportunities that I can find where those traditional firewalls that sort of got in the way of making progress weren't really making any sense. We have to be clear about conflicts of interest, and we are, but that shouldn't be a reason not to think about creative endeavors that fly in the face of such great opportunities that we now see in front of us.
Thank you very much. If I can, I'm going to go to my very patient friend from Virginia who's was here early and has waited a long time, Mr.
Thank you,
Ridge.
Chairman Cole, and I appreciate Dr. Collins and your colleagues being here today, and I'm learning a tremendous amount, and I too respect the work that you're doing. I want to first frame this not as a question, because I'll get to a question, but I did take note of your comment about how helpful it would be to have confidence in continuity of funding, and I've transitioned from House Armed Services to this committee, and I was struck in my service on that committee where our senior uniformed and civilian officials would say the same thing about just how beneficial it would be for us to be on regular order. And I know Chairman Rogers and Chairman Cole and really all of us on the committee have been strong advocates for this, and so I'm going to continue to fight for that, and I know my colleagues will as well. But I just took note of what you said, and I just wanted you to know that. I have an incredible district, highest concentration of men and women in uniform in the country, Virginia's 2nd Congressional District, and by the nature of the commands that are there, a disproportionate loss. So I want to talk for a moment about the PTSD. Now, I know that there is some funding for it included in your budget. It's $79 billion, and I believe it's to go to $81 billion. Million. Better get that right. Okay. All right. But my point is this: is that help me to understand. By the way, from the President on down, the First Lady, this is a shared American value. I do not question for a moment anyone's commitment to this. That said, I didn't see it mentioned in your budget justification, and I know that the Department of Defense and also the VA is working on this as well, but help us to understand where this falls in the priority level, and is it getting the attention even within your own internal documents that I think it merits?
I appreciate the question, Mr. Ridgell. Let me ask Dr. Insel, who directs the Mental Health Institute, where PTSD research is particularly a strong priority, to respond.
Well, so very quickly, because of the hour, our institute was actually founded in 1946 and charged in 49 to deal with the problems of veterans. So this is something we've been at for a long time. It's part of the DNA of the institute to try to figure out what causes PTSD and how best to treat it, how to prevent it. We have been working really closely with DoD, and this is one of those areas we were just talking about the relationships with industry. This one we've really taken on in a very joint way, especially with the Department of the Army. And so the Army and NIMH have worked together on the STARS initiative, 100,000 soldiers partnering with us to try to understand over time what causes not only PTSD, but depression, high-risk behavior, and suicide, which is the worst outcome here. And I must say that having worked as closely with the DoD as we have over the last 3 or 4 years, that's been a great inspiration. That study has now just completed its first phase, moving into its second phase. Already I think we're getting some insights about both the cause and the best interventions to make sure that people who develop mental health problems don't go on to suicide.
The question of allocation generally, how much is allocated to one disease or particular challenge that we face. Dr. Collins, could you help me to understand, especially when things need to be reallocated? Because, you know, whatever your own maybe experience has been, and we've, like most American families, we've had loss due to Alzheimer's and cancer and things like this, but how does all that structure? Because I'd like to see, you know, a higher allocation for the topic just mentioned. What our service members are facing, but how is that process unfolding?
That's a question that many people ask, and they should, and it is an ongoing organic process of looking at what is the public health need, what are the scientific opportunities, what's the current portfolio look like, and do we have gaps that we need to fill? And we are constantly doing that kind of analysis. We have more tools now than we used to, a whole series of ways that we can look at our portfolio and figure out whether we have the balance out of whack in terms of where our dollars are going and where the public health need is. But sometimes there are rare diseases that we could learn a lot from about common illnesses, or which simply affect a few people who desperately need help. And if we did everything on the basis of public health need, we would probably neglect the rare diseases. In other situations, Alzheimer's comes to mind, where the burden on individuals and their families and the cost to society is so daunting that we feel we have to push even harder as long as the scientific opportunities are there. So it's a constant sort of recalculation. And of course, all of this would be easier if we were not in a circumstance where, frankly, we are underfunding virtually everything we do versus what we could be able to do, given the talent that's out there.
Thank you for your comments, and I yield back. Thank you, Mr. Chairman.
Thank you very much. Just for informational purposes, as my colleagues here know and as our witnesses know, we do have time constraints this morning. So I'm going to go to Mr. Dent so he has an opportunity to ask his question. I'm going to then go to Ms. Delora so she can close us out as a committee, if that's all right with everybody. So, Mr. Dent, you're recognized.
Thank you, Mr. Chairman, and thank you all. And thank you for receiving us a few weeks ago up at the NIH. It was a very interesting program, and I got a lot out of that. So thank you for that. And Dr. Collins, I just wanted to mention that an analysis of the National Cancer Institute data from 1975 to 2005 found that that liver cancer incidence rates increased by more than 300%, from 1.6 to 4.9 cases per 100,000 persons per year. In fact, liver cancer has seen the second largest annual percent increase in incidence of any cancer in the U.S. other than thyroid cancer. Historically, the survival rates in liver cancer have been pretty dismal. The 5-year survival rates of persons diagnosed between 2003 to 2009 is only about 16%. These survival rates are second worst among all cancers, only slightly better than those for pancreatic cancer. And yet the NCI has no dedicated specialized program for research excellence on the liver or liver cancer project. Can you tell me why, and wouldn't this accelerate the pace of liver cancer discovery?
I appreciate the question. Certainly, liver cancer is a condition that many components of NCI are involved in working on. Whether there's a specific division focused to it, certainly there's attention to it. And of course, liver cancer is particularly likely to appear in those who've been infected with hepatitis C, which is one of the great, wonderful success stories of the last few years in terms of coming up with the therapeutic that can actually cure people with that disease, and should therefore reap some rewards in terms of reduction in liver cancers downstream. Again, I will have to take for the record the opportunity to respond about the organizational part of NCI in liver cancer, and I can no doubt fill you in on where that work is going on and how it's being coordinated, if that would be helpful.
That would be very helpful. Thank you. And also this question to you also, Dr. Collins. Maybe Dr. Fauci wants to jump in on this one too. I recently met with CDC Director Dr. Frieden. And one of the issues we discussed were the recent fatal outbreaks of antibiotic-resistant bacteria across the country, including my home state of Pennsylvania. This threat posed by antibiotic-resistant bacteria, also referred to as superbugs, is so serious that last September President Obama issued an executive order declaring that combating superbugs as a national security priority. And of course, superbugs are highly contagious, untreatable infection that spreads easily in the hospital setting, particularly. And can you tell me if NIH is collaborating with the CDC to study, contain, and trying to find a treatment or cure to these antibiotic-resistant bacteria?
Yes, intensively, but let me ask Dr. Fauci to say a word.
Thank you very much, Mr. Dent. We are very intensively involved in collaboration with the CDC. As you know, with the President's strategic plan and the executive order and the CARB program is a multi-agency U.S. government involving the CDC, the FDA, the Department of Agriculture, and HHS in NIH. Our fundamental mission in that multi-agency approach is fundamental basic research to understand the pathogenesis, particularly now with the new high-throughput sequencing capabilities that we have to examine a wide array of quasi-species of microbes that are resistant, have put us into a situation where we can do things that were really not imaginable years ago, and being able to pinpoint the mechanisms. Number two, we started a few years ago and have now amplified it with the President's request of $100 million more for antimicrobial resistance in the 2016 budget, what we call an Antibiotic Resistant Leadership Group, ARLG, which is part of our broad network of clinical trials to be able to do some studies that you can't do in a given individual institute because of the fact that the incidence of outbreak of 1 or 2 cases is very difficult to get good clinical data. So we now are collaborating with the CDC. They're doing mainly surveillance, and we're doing fundamentally the research. In addition, and finally, we're doing work on developing vaccines for some of these very difficult microorganisms that are highly susceptible when you think in terms of people, for example, who have transplants who are immunosuppressed. Not only MRSA, but some of the others such as CRE or carbapenem-resistant Enterobacteriaceae. So the NIH, in summary, is very heavily involved in this in great collaboration with the CDC.
So you have a request for an additional $100 million, and that will be sufficient to...
In the President's 2016 budget, there's a $100 million request for antimicrobial resistant research.
Thank you, and I will submit the balance of my questions for the record. Thank you, Mr. Chairman.
Thank you very much. Now for our last round of questions, go to the gentlelady from Connecticut.
Thank you very much. And let me just follow up on my colleague, Mr. Dent's questions on antibiotic-resistant bacteria. There is a significant increase in the budget. And can you take a moment to talk about Teixobactin as a new technique that's been discovered to deal with this? And also, there is some misunderstanding of how long it's going to take to be able to use that. Can you give us an idea about how long, a timeline for the potential availability of, and I don't know if I'm pronouncing it right, but Teixobactin, right? And recently I was in Haiti, and I met a doctor who described the devastating effects of the antibiotic-resistant tuberculosis. Are there any drugs in the pipeline to treat a drug-resistant TB? And again, finally, I understand you're dealing with looking at a database for this effort, antibiotic-resistant infections, but there are many of them, to put it simply, in my simple language on this. But if the database was going to hold all genome sequence data for the 10 deadliest antibiotic-resistant pathogens, what kind of an effort would that entail?
Okay, three questions. I'm going to do it quickly.
I wanted to get you on. Talk about what's happening in Liberia.
All right. I'll go quick, President.
Please, Liberia and ZMAP.
Okay, we'll do that. Teixobactin. So the NIH is very pleased with this because this was an entirely funded NIH effort to the tune of $20 million, and we now have a new class of antibiotics that was developed from the soil. And the issue is we've got to be careful. It's not going to be tomorrow or next month where that's going to be available on the market because we still need to continue to do preclinical studies in the animal model before we can get into a human situation. So I'd like to say it's going to be around the corner, but it likely will be over a year before we do that. The good news is that it's a brand new concept of an antibiotic that essentially skirts the resistant mechanisms that other types of microbes use against the common antibiotics. So it will likely be good against microbes for which there are multiple resistance. So that's the good news. TB, good news here also because we've partnered with drug companies, with several of them, particularly Janssen and Janssen, to develop now new drugs that are good against some of the multiple and extensively drug-resistant tuberculosis. So we do have at least one and now two in the pipeline. If you had asked me that question last year, I would say we really don't have anything new. Database, and this is something we do very well. We have phenomenal sequence capabilities now. So we're going to be able to do that. In fact, that's one of the things that we put as a high priority, is to be able to use our technologies to get databases of essentially all of the various versions and iterations of antimicrobial resistant microbes and be able to share them. And as we do at NIH, it's always open access. So everything we do is open to the general public.
Ebola and the trials that started
Right.
in Liberia.
Right.
And then ZMAP trials as well.
Okay, vaccine trial started February 22nd in Liberia in Monrovia. My deputy is there now overseeing the trials. We started off with a phase 2 for 600 individuals where we'll access slowly to make sure it's still safe and immunogenic. And then by the end of the following week, we're going to go to the full total of 29,000 people. So it was the vaccine that you mentioned was developed by Nancy Sullivan in the Vaccine Research Center, together with the VSV vaccine, which we collaborated actually with the Department of Defense, getting back to the other question about our collaboration with the Department of Defense. So those two are ongoing. I mean, it's up and rolling. ZMAP ZMAP was very, very favorable in animals. We don't know if it works in humans. We've started a comprehensive protocol that was announced 3 days ago by the Ministry of Health in Liberia, actually at the same time that the president of Liberia was meeting with our president here, right here in the United States. It started a few days ago, and what it's going to do is to compare standard of care, namely intravenous replenishment of fluid, against standard of care plus ZMAP. And as you know, ZMAP is a cocktail of 3 separate antibodies directed against the Ebola virus. And as I said, it looked very good in animals, but we need to prove definitively if it will work. And as I said, both of those are NIH-driven trials, and both of them are ongoing in Liberia right now.
Thank you. Just, first of all, Dr. Collins, thank you very much and your colleagues for being here this morning. I have no doubt this is not only the most brilliant panel we'll see all session, it's the most popular panel we'll see all session long. So thank you very much.
We need to have a group hug. I did the best. Love you. You're fabulous.